Here we go. Okay, so episode 7, I believe, of our Belltower. And this one was one of the ones when we first talked about this. I was really intrigued by the idea that somebody who's in the medical field could help me, like help me help you type of thing. And I come from a family of physicians. My grandfather was, and my uncles and things like that, but I've never felt like I really had an understanding of how decisions were made. And as someone who's been down that road of having some big medical stuff happen, I'm just really intrigued to hear from you today, Bethany, about that. So I'm going to turn it over to you. Give us a little quick kind of bio first about who you are and how you came to Taylor and all that stuff, and then just jump in. Okay.
Okay. So yeah, I'm Bethany Hodge. I moved to Upland in 1989 when I was 3 years old and my dad got a job there. And I grew up with Taylor as my backyard, and then I went to Taylor, and then I worked at the clinic in town for a year. So I was very Upland Taylor until I left for medical school, and then I have not moved back in many different ways. My parents do still live there, so yeah, I think that's why I have so many feelings about things that get posted over on the page, because this is my childhood, this is my, all these kind of things kind of thrown in the same mix. But yeah, currently I am an academic pediatric hospitalist for the University of Louisville, which means that I practice medicine in a hospital, in a children's hospital. I only see kids that are sick enough to be in the hospital. And I do that in Kentucky, which adds interest at different levels too. I also lead the global health education program for the School of Medicine and work with the Department of Public Health, and I do disaster medicine, and I find fun things to do. That's what I do. And the idea for this talk kind of came out of, so I'm a pediatrician. I'm a very specific kind of pediatrician, but that doesn't stop everybody from saying, hey, you're a doctor, can I, get advice on this, or look at this rash at parties that happens, things like that. And trying to figure out, how do I explain what I can explain about medicine to help people make better decisions or have better conversations with their doctors, while admitting that I don't know all the things about medicine, because there's too many to know. Specifically, this kind of came out of discussions I was having with my father, who is aging and having to look at different surgical options for different problems he was having, and my brother-in-law, who had early stage colon cancer, and friends going through fertility treatments and all sorts of stuff. Everybody's got stuff, and the conversations you have with your doctor, I think, are really important to end up where you want to be with your medical care. So I thought maybe this would be helpful. Let me share screen. I did make a PowerPoint because that's how I think. Yep, it's over here in the corner. Okie doke. Do you see my lovely PowerPoint?
Perfect.
Okay. Presentation mode. Okay. Yeah, and I did actually graduate in 2001. So I probably overlap with a lot of people, as in I was around, but I may not have really been on the campus scene quite as much. Just one of those snot-nosed kids running around with when other people were there. Okay, so yeah, so this is who I am. I'm a pediatrician. Anytime doctors are talking, they give their training, because that's what we do. I don't know. It tells you where I've been. And now I'm at the University of Louisville. And I think one thing that is interesting about doctors, and since I do things with medical students and med ed, you get these kids out of college, or sometimes there's some other interesting life paths, but you get them at the beginning of medical school, and we do all the same things with all of them, whether or not they're going to grow up to be neurosurgeons or cardiac surgeons or pediatricians or OBGYNs. They all kind of start out with the same thing. So even as different as doctors are in practice and in personality and things like that, we kind of start out in the same place, where we have preclinical medical school where we're doing a lot of classroom work, your gross anatomy labs, all that kind of stuff. There's clinical medical school, the second 2 years, where you're doing rotations and you go to every different specialty and do them for a while to try them on for size, to learn things, to figure out what you want to be when you grow up, kind of thing. So You'll do inpatient pediatrics with me, you'll do surgery with somebody else, and that's the second 2 years. Then you go into your residency, which is where you learn the specific skills to that specialty. So a lot of medical school and even your clinical years is learning how to learn, learning how to approach patients, how to think about disease. And then residency, you get all those technical skills of like, this is how I treat this, this is how I do this surgery. And sometimes there's fellowship added on to the end of that. And then, if you do this quickly, you're a real doctor by the age 30, like real life comes real late for us. If you are doing something complicated like neurosurgery or vascular surgery or ENT, or with a subspecialty, you might be 35 or older by the time you're actually in practice by yourself. So you kind of like, we start out all the same and then get more and more specific, especially if you go through more and more training. And the thing about differentiating, that's a biology joke if anybody's in on that. That's what cells do to become the cells they're going to be. And then, so one thing we do, especially in the preclinical and clinical years, we play this sort of exercise, this game called doing the differential diagnosis. And so it's a teaching method where we sit around and say, okay, 35-year-old male shows up with a headache. What's your differential? It may be as broad as that, where you have a little bit of patient information and then the really broad symptom. And you're supposed to think through, what are all the things this could be? All the things. So you start looking at all these different categories. So for something broad like headache or fever or rash or something like that, I can come up with a disease in all of these categories, and that's what I'm expected to do as an academic exercise. Think through what toxins could be giving him a headache, what infectious disease could be giving him a headache. And then as you go through the exercise, they give you a little bit more information, how long has it been going on, what helps, what makes it worse, all those questions that you're used to your doctor asking you when you come and say, this thing doesn't work, and then they start asking you more questions about history, about details, about what kind of pain, what's it do, is it always there, is it getting worse over time, all those kinds of things. And then you'll get some physical exam information. So, the rash looks like this, it feels like this to the fingertips, it covers this part of the body. And then you're supposed to refine from having a disease for every single one of these categories down to what you think it most likely is and what tests you're going to order and what would tell you that you're on the right track versus the wrong track. So this is how we're taught to think about disease and why we go through the process that we do. The more specialized you are, or if there's been false information along the way, false positives, false negatives, it points you in the wrong direction and can make it hard to go back to this big picture where you're reconsidering everything. If you are to the point where you're seeing a neurologist for your headache, they're probably not going to think about as many infectious disease or other kinds of issues, because they're pigeonholed in a way by their specialty and what they normally treat. But it's always fair to ask your doctor, hey, I'm presenting you this collection of symptoms, what's on your differential? That's a fair question to ask, to get them to say, this is what I'm thinking about, this is what it sounds like to me, this is the pattern that I see emerging from the answers that you're giving me. That's a fair thing to ask. And then, but I think there's this thought for patients and for doctors that if I play that game right, if I get the diagnosis right, then everything else is easy, right? It all hinges on having the correct diagnosis. And then we'll be able to fix it or treat it or something, and everything will get better. But unfortunately, as everybody knows, I feel like everybody's got a story about, I tried to have this thing treated or talk to a doctor or a medical professional about this, and it just didn't go well. And it's partly because there are some flaws and caveats to that differential diagnosis process that can make that really difficult. So for us, we have to be asking all those right follow-up questions, getting all the correct history. And we need a patient that's willing to tell us everything honestly too. A headache that presents, after working out is going to be a totally different headache than one that presents with, oh, I'm also producing breast milk now. Like those little facts, radically change which direction I'm going with what to do with this headache question. But if they don't want to share those things, or if there are things that they don't connect in their mind to being relevant, or that they're unwilling to say, or they just, something like that, it's hard to get all that correct history. There is a process to ruling out and ruling in diagnoses. And your headache, it probably is stress and dehydration, because that's what most headaches are. But if the fixes for that type of headache don't work, then we have to go back to the drawing board and redo the process. And so we need a patient and a doctor who will stick in relationship together long enough to do all those rounds of figuring out until you get it right. I think I've noticed, especially with my parents, they're like, well, my doctor told me to do this. It didn't work. I guess this is life now. And I'm like, no, that's not how this is supposed to work. Like, go back, re-talk to them, tell them how this, did or didn't work. But if you don't have a doctor that's willing to do that, or if you don't have a patient that's up for those rounds and rounds of discussion, then you never quite get to the right thing. I think with the correct diagnosis, we want it to be a tiny box. You have this, it is called this, it is treated like this. That's it. But really, symptoms and treatments belong in a swirly Venn diagram world, where your headache may be something serious, but the stress in your life is also layering over that, or this medication is also causing a side effect, even if it's doing something good for you. Like there are just so many different types of things that are piled on top of each other, that, tiny box and this goes to this answer and everything will work is much more difficult to find out in real life. Especially what we've been finding out in the past 12 months, there's limits to testing and knowledge. We did not know a damn thing about this thing we were fighting when we started dealing with COVID. And we didn't have the testing, and we didn't have correct testing, and we still don't have as much testing and as much detail in our testing as we want. There are disease entities spinning out of COVID that we've never seen before. We had to reconceptualize the entire disease. It doesn't act like previous coronavirus. It doesn't act like flu. It acts like this totally new thing that we had to totally learn about. And so, sometimes your patient won, and we have a lot to do to figure out what's going on with that. When I say that there are biases of many types, I mean that in all the senses of the word. We definitely know that there are biases against different types of patients, whether that's race, weight, gender, other things that they've got going on, homelessness, history of drug use, history of psychiatric illness. That is a type of bias that can influence the relationship between the patient and the doctor. And then there are biases of logic, which is what we kind of go over when we try to look at what went wrong in a mortality and morbidity conference. It's a real fun time. Those ones, they're a laugh a minute. But we're trying to look for, okay, why did well-intentioned people get it wrong? Was it a lack of knowledge? Was there recall bias? Was there bias that, oh, I just saw 3 brain tumors, so this must be another one, kind of thing? They're all the kinds of logic-based biases that can affect the way that we do or don't get to the correct diagnosis. And then I think the last one too is what's really come out to me as I've had discussions with family members and other people, that what success looks like to the patient may be different than what the doctor is calling success. And I say that because I think especially those specialties that take a really long time to get into and you're really deep into it, a fertility specialist says success is, I got you pregnant. An oncology specialist, their success is, you don't have cancer in 5 years. There are different things that they're measuring sex that are held up to our work as you are successful or not successful based off of these metrics. A transplant surgeon wants his transplant to be healthy. A surgeon wants no complications or infections. Pediatricians, we want people to grow up and turn into adults and be healthy, and then we release them into the world. Not all the time, but a lot of the time. So success looks different. And I think that's where some of the interesting conversations can happen if you've got a good doctor too. The thing that's supposed to resolve a lot of these issues is the quote unquote evidence-based medicine. So as we went away from I practice medicine this way because this is the way my teacher taught me, and kind of an apprenticeship model of learning how to do medicine. We now have this evidence-based medicine, which sounds, real great, and it is. But that's why we do studies, how we use studies, all those individual papers that are published in the Lancet and JAMA and all that kind of stuff. How do I take this paper and say, does this apply to my patients? Is this something that changes the way I do medicine? And different doctors are better or worse at looking at literature. It's something that we're expected to do, but it's not trained as much as I think it could be. To be able to look at a study and say, is this a good study? Is the selection of the patients for the study biased in some way that affects the results? Did they really measure the right thing? Is the evidence strong enough? Is this applicable to the people I'm seeing? If they did a study in adults in Vietnam, does that matter to my pediatric practice in Louisville, Kentucky? I don't know. We have lots of layers of how to look at studies and how to try to say, okay, we learn this through doing the scientific process, but what do I do with this in my everyday practice? So evidence-based medicine is supposed to help, but it only works if they've actually studied someone like you to know if this applies to you or not. So when my dad was having to decide whether or not he was going to have his gallbladder taken out, he was like, well, I'm just asking the doctor, what is the % likelihood that this is going to solve my problem? Why can't he answer that question? And I'm like, that because that's a numbers-based thing, that means we need a study of a couple thousand Bob Hodges with your exact height, weight, build, history, all those kinds of things going on, and then he could tell you how many of 1,000 people just like you that it helped. If that study hasn't been done, I don't have that information. And we live in that world in pediatrics a lot because people don't do studies on children. It's higher risk and more difficult to do. So we do a lot of things that is like, we do have to translate some things from other parts of medicine or from adult populations into kids. But ideally, you have someone who has done the study already that really matches the people that you're talking about, that really matches the situation that you're talking about, and then you can give your best advice. With all of this too, so when my brother-in-law, healthy 47-year-old, I think at the time, was diagnosed with very, very early stage colon cancer on a colonoscopy. And the question was, what do we do? Right? Like, we want him to live. That's a thing. We don't want him to have cancer. What do we have to do to make that happen? And the the thing that had the least amount of evidence for it was a watch and wait kind of perspective. After he did chemo and radiation short stints, the oncologist who wants to make sure you don't have cancer in 5 years is like, well, let's take out your whole colon and then you can't have cancer in it anymore. And he's like, I also can't poop out my butt at that point. Like there are some trade-offs here that are increasingly important to me as a healthy, functional 47-year-old. But there wasn't any study in healthy, functional 47-year-old men to say what the watch and wait approach would take, what that would mean, what his outcomes might be. And so it was really hard to stay in relationship with those doctors once he's like, I think I'm going to keep my colon. Is that cool? And they're like, not for my numbers, it's not cool. I can feel more confident you're not going to have colon cancer if you don't have a colon. I see what you're saying about the pooping out your butt part, but they would still say their advice was, let's take the whole colon out. And I had to explain that level of thinking to him. Like, again, what does success look like to this person? What does success look like to you? Do those two things match? Why do we not have an answer on why this, on the watch and wait in you? Because nobody studied that population. They don't have anything that they can confidently say, I know this is going to, or I have a high probability this is going to work, because a study hasn't been done. So when you are the first one trying something, then that can be its own source of interesting challenges as well. So I think in the end, there's only one you. But we as doctors don't know what that means unless you tell us, right? So if you do have a superseding goal, pooping out your butt might be one of them, or something else, then we don't know how to incorporate that into the overall medical plan unless you tell us. I don't like it that finances and logistics and things like that play so much of a role in medical decision making in the US. I think it's usually done passively instead of purposefully, though. We tell you to go do something and you just don't kind of do it because you're not physically able to get to the appointment or the medicine is too expensive. And we don't have a good way of communicating back to say, okay, um, I would like to treat my hypertension, but I need you to write me for a cheaper drug. Or I would like to pursue this option, but I can't get to the appointments or I can't get to the specialist or whatever. Like those kinds of feedback loops, I don't think we do enough of. And I don't know that we always give people space to say, okay, this is what medicine might say, but what is going to work for your real life? In the instances where I have had to do that, when I'm working with Amish patients or something like that, they pay cash and don't have electricity. I know that if I send them home with a nebulizer machine for albuterol, they can't use it, right? Like in some of those instances, things are so stark that we know we need to change practice. But I don't always know why there might be other things in people's lives that are important or conflicting unless they tell me. So I think that would be another thing I would encourage. It's fair to say, yes, I agree with you on this part of the treatment goal. I don't agree with this part. Or yes, fertility specialist, I'm interested in getting pregnant, but my line is drawn here. I don't want to do IVF. Or we're willing to do this many rounds of a medication, or I just want to know if there's a medical reason why we're not having a child. Like explaining your goals so that they don't assume they're the goals of their specialty and impose them on you, I think can be another thing. And if you're deciding to not do something that a doctor has recommended, it's a tough conversation, and some doctors will be total dicks about it. That's absolutely true. But a good doctor will say, okay, what am I missing here? What is it that we're not addressing properly? What could we do better? What part do you want to work on? Things like that. I think that hopefully a good provider will have those conversations with you and not just say, fine, we're done with you. But that can be tough too. So we're balancing evidence-based medicine, what the numbers and the statistics are telling us to do, but then there's all these other things that I think are valid, but we have tougher time having conversations about things like risk tolerance, goals for care, your social and family needs, your pain or side effect tolerance, and all those kinds of things that I was just talking about. So how do I answer the question, what do I do, doc? I do still take the time to establish my credentials. Like I'm a pediatrician, so understand that I'm not an expert in blah, blah, blah that you're asking me about. But tell me what your doctor is telling you. Tell me the choices that they're presenting to you. Let me try to help you understand what your doctor may be thinking and why they're presenting it that way. And let me emphasize that you have freedom as a patient to have more conversations, to look at other options. But if you don't communicate, if you don't try to, see if the relationship can continue with that provider, then things will shut down. That it will become increasingly difficult if you don't kind of keep working the process with the doctor, telling them what they've gotten right, what they've gotten wrong, how you want to move forward. I think that's the best way I can say for these people going through difficult things to try to keep getting good medical care, but also not just being having decisions made for them or put upon them in a way that's not working out in other ways in their life. When it's within my own specialty, what do I do about this issue with a child or a sick child or things like that? Becoming a parent has definitely changed my perspective on a lot of those things too. And I find myself saying a lot of things like, breastfeeding, it's natural, but it's hard. And it kind of just acknowledging that just because I know it is book correct, I also know that it is life hard. And so we figure out, okay, what does breastfeeding do for you? What does breastfeeding not do for you? What support would make it easier for you? What would make it doable? What do you value about this? I ask a lot of more of those questions, which it's hard to get paid for. I'm not going to lie. There's not a lot of places that want you to take the time to do all that, but I want good outcomes. I want good outcomes for my babies and for my moms and all those people. And it's the long long story arc with patient care instead of the short story arc of like, okay, fix your problem, leave the hospital, the end. But that's how I practice medicine, and that's how I'm teaching my med students so that we can hopefully be better doctors for people. And that's it. That's the end of my talk.
That is terrific. Thank you so much. Go ahead and stop sharing your screen so we can see, and maybe we can take a couple questions. I will say that for me, what was so valuable, Bethany, was hearing that the idea to ask my doctor, what is your view of success? I think that just that feels like a comfortable question I could ask. And then also knowing that one of those criteria could be pooping out my own butt is also very helpful to know that that could be something that I can consider a criteria. I've had a successful day today just based on that.
There you go. There you go. Good job.
Thank you. So I'll open it up. Does anybody have any questions? We've got about 4 minutes. We can grill Bethany, or a rash that you'd like to show her. Yeah, Christina, go ahead.
So was there a diagnosis that you were particularly proud of figuring out?
Yeah, actually, the differential diagnosis thing really helped me. I was in practice in a community setting and for a hospital thing, and a little kid was brought in that was having new onset seizures, which can be a really, really scary thing. What are we dealing with that is causing these new onset seizures in a toddler? And we were getting ready to do a bunch of tests and do a bunch of stuff, and I noticed she kind of had this weird brownish, purplish splotches on her arms, and I was like, somebody want to talk to me about these weird colored splotches? And the mom said, oh, I think it's fingernail polish. I'm like, okay, talk to me about that. What else is in the drawer with the fingernail polish? And she's like, oh, let me call somebody at home. So they go to the drawer with the fingernail polish and dig through, and they found some expired medications in there, one of them including Wellbutrin, which is a medication, well, it's the anti-smoking version of Wellbutrin, which ingestions in children can cause seizures. So once we but I went back to the differential going, okay, what infection could this be? Well, she's not acting like she has meningitis. Could this be a brain tumor? Well, everything else is fine. Could this be, this? Nothing was making sense. And I got to toxins, and I thought, okay, what could she have gotten into? And connected it through the being covered in fingernail polish to she was in a drawer in the bathroom she shouldn't have been in and had medication ingestion. And I canceled the rest of the tests and just said, let's call poison control and work through it with them. And she ended up being fine once the medication was out of her body.
What a great story. I hope you're proud of that.
I am. I mean, it happened like 10 years ago, and it's still the first one that pops in mind where it's like, yeah, that tool can be useful, especially when things are not adding up. Like go back, it's just like, go back to your basic training, do the process and see what comes out of it.
I love that. Anybody else?
Nate? I have a question, and it's kind of a big question. So like, if you need to be super brief with it, don't worry. But there's kind of a growing trend in the US, specifically like for psychiatric patients, of self-diagnoses because of unaffordable healthcare or inaccessible healthcare in so many different ways. So, I mean, as a doctor, like, what do you think of people self-diagnosing? I'm sure it doesn't happen with children quite as often, but I mean,
well,
just
of course it does. So I think, especially with pediatrics, the thing about Dr. Google is that it does not give you scope. It says you have elevated liver enzymes. It doesn't tell you whether it's a little bit or 5 times as high as it should be. So I think it's hard for a lay person, because you may go through a list that's something that a search gives you, and you're like, I check all these boxes. I must have hemophilia. And if you bring that to a doctor, they're like, for so many reasons, no. But the psychiatric diagnosis things, I think that is a little bit more difficult because there aren't so many, pee on a stick and I tell you whether you have this or not kind of conditions in that realm. That'd be super handy if we could have that, but we don't. And the other thing is, how are you biased by you being the person experiencing the symptoms versus the outside? I think there is some worth of an outside observer when you're looking at symptoms or looking at disease. So I think it's a good place to start. And I think it's worth bringing up to your doctor, hey, have you thought about this? Or I feel like I fit in this category. Can we talk through it? But try to see them as a useful outside observer. and see if what else it matches, because we're also always looking for patterns. And sometimes, when your doctor looks at you like this, it's because some things fit a pattern and something clearly doesn't fit the pattern, and then are trying to figure out why doesn't this all snap into view. So make them talk to you about what is fitting a pattern that you're thinking of, what's not fitting a pattern that you're thinking of, and how do we reconcile that? Is that helpful at all?
Yeah, and super interesting too. Nathan, was that good? I mean, that's broad. That was a big question.
Yeah. I mean, it's a huge question. So
Yeah.
It's just not one you get to ask doctors very often.
Yeah. I mean, okay. So I will say that if you come in with a stack of articles and you're like, this is why I have hemophilia, and the doctor is like, yeah, but no, I think that's when we feel tension. And I think some of it does come back to the ability to read a study or have the study be somebody that is similar enough to you. I had parents bring in kind of natural medicine articles that were based on adult men and wanted to apply it to their special needs daughter, and I'm like, these are apples and oranges, and I'm really not comfortable saying, well, yes, you have 3 small articles that say we should be using coconut oil instead of seizure medicine, but I'm not comfortable with that because of XYZ reasons. So I think there can still be discussions, and there'll be times when I think things fall into the, I don't know if it'll work, but I don't think it will hurt, sure, go for it kind of category too. But a lot of it is with the evidence that you're bringing. Does it have the scope of your symptoms? Does it really encompass that for good or bad? And is the study population similar enough to you that we feel like we could extrapolate the results and say, yeah, okay, I can see how this would be you as well.
Makes tons of sense. Well, guys, we're at time. Bethany, thank you so much for sharing that with us. I've gotten so many, look at all my useful things. I don't know why I don't carry a big paper with me, but I've got
notes.
so many useful things out of it, and I really appreciate it. And just, taking the time, and we all love it. And thank you so much. Round of applause, everybody.
Thank you.
Bethany.
Yeah, I think, I want people to still want to see their doctors, and that's hard for a lot of people for different reasons. So
yeah, I think, as with most things in life, conversations work. Open, honest, direct conversations that are candid and full of care and love actually work. So it works in this case too. So it's fun hearing from you on that. Thank you for that.
All right,
everybody. Right now, we don't have a meeting scheduled for next week, but I'll let you know what I come up with, see if I can rustle the trees and get someone to talk to us next week. If not, I'll let everybody know on the page. But it's good to see everyone. Thanks for showing up. I'll get this up and posted pretty soon. Thanks. Obligatory Zoom wave. Goodbye, everybody. Goodbye.